Intertrochanteric fractures. Anatomy. Intertrochanteric fractures occur in the extracapsular region between the greater trochanter, GT, and lesser trochanter, LT, of the femur. Muscle forces, such as from the hip abductors, can cause deformity and shortening of the fractured bone. Classification. 1. Evans classification, based on the convertibility of unstable fractures to stable fractures. Stable fractures. Undisplaced fractures. Displaced fractures that, after reduction, restore the medial cortical buttress, making them stable. Unstable fractures. Displaced fractures where the medial cortical buttress cannot be restored with reduction. Comminuted fractures with significant displacement and inability to restore the medial cortical buttress. Reversed obliquity. A fracture pattern that extends from the medial cortex proximally to the lateral cortex distally, causing medial displacement due to the pull of the adductors. 2. Kyle classification. Descriptive. Fractures are classified based on the degree of displacement, comminution, and involvement of surrounding structures. Mechanism of injury. Direct trauma, typically in elderly patients due to falls, causing fractures in the intertrochanteric region. Treatment. 1. Conservative management. Indicated for patients who are unfit for surgery or are non-ambulatory, e.g., demented patients. Methods. Traction for 4 to 6 weeks, followed by rotational casting, balanced cast. 2. Operative treatment. Indications. For displaced or non-displaced fractures, and in patients who are fit for surgery. Methods. Dynamic hip screw, DHS, used for stable fractures. Consists of a lag screw and side plate. Plate angle typically 130 degrees to 150 degrees, most commonly 135 degrees. Key considerations. Avoid malrotation, varus positioning, and posterior sag. Lag screw length should be managed to keep the tip apex distance less than 25 mm. The screw should be positioned centrally on AP and lateral views. Intramedullary nailing, IMN, gamma nail, used for both stable and unstable fractures, including comminuted fractures and those with subtrochanteric extension. Advantages include limited exposure and reduced blood loss. 3. Arthroplasty. Indicated for severely comminuted fractures, failed internal fixation, or cases with osteoarthritis. A calcar replacing prosthesis may be necessary in these cases. And 4. External fixation. Indicated for open fractures or highly comminuted fractures. Complications. Implant failure and cutout. Most common complication, especially in the first 3 months. Causes include tip apex distance greater than 25 mm. Eccentric placement of the lag screw. Improper reaming, creating a second tunnel. Unstable reduction. Osteoporosis. Management. Acceptance of the situation with proper monitoring. Revision surgery if necessary. In some cases, arthroplasty may be required. Key notes. Reversed obliquity fractures should be treated as subtrochanteric fractures due to their tendency for medial displacement.